When to stop storage, improving conversations about unused embryos is the topic that we're going to be discussing this evening. And the hashtag for the event is embryo choice. And the discussion this evening has been made possible thanks to the kind support of the Scottish Government. And PET is extremely grateful for that support. I'm Sharon Norcross, the director at PET, and I wanted to start off with a bit of background to this discussion. Many people who have fertility treatment will end up with embryos that they will not use, and this can be for a number of reasons. The best reason, of course, is that they've successfully completed their family. For others, it may be that they've had one child but can't afford any more treatment, and others, life's thrown them a curveball and they're not going to end up using them. And for some people, using these embryos can be very challenging. You may be the type of person who holds on to things just in case. Not to have embryos in store may feel like your tempting fate. The options that can be offered to patients are donating for use in research, for use in training in the clinic, to donate them to other patients who face difficulty conceiving a child, consenting to allow the embryos to perish. And then there is the sort of non-option, I suppose, not something that the embryologist or whoever was making the call would offer, and that is delaying or avoiding the decision. For example, when the consent to store runs out, not replying to the clinic, not paying the storage fee. And that can happen because people put it in the too difficult pile. And consequently, I suppose you'd say they choose, in scare quotes, that final option, or perhaps more accurately, the final option occurs by default. And now patients are required to renew their consent every 10 years for an overall maximum of 55 years if they wish storage to continue. I then wanted to just mention quickly about using embryos in research, because that is a topic that PET explored in our research into public attitudes and understanding of fertility, genomics and embryo research. And this research was undertaken by Ipsos when they surveyed a representative sample of more than 2,000 people across the whole of the UK. And the question that we asked was, to what extent do you support or oppose the use of human embryos in scientific and medical research to help understand and develop treatments for congenital disease? And you'll see from the results that 41% of the general public supported embryo research, and that this far exceeded the 19% who opposed such research. That's something just to sort of bear in mind, I think, as we're having this evening's discussion. And tonight we have an excellent expert panel to discuss how to improve the conversations about these unused embryos. So we have Joanne Leitch, we have Chien, and we have Sharon Martin. Joanne is lead scientist at Fertility Scotland and scientific lead and lead clinical embryologist at the Glasgow Royal Assisted Conception Service.
I want to have a bit of a discussion about the embryologist perspective around improving those conversations about unused embryos. And just to give a little bit more of a context of what the embryologist does and how they're involved in those discussions. So just an overview is a very quick landscape of embryo storage in the UK. I also want to talk about shared decision-making as a concept and a process that can be used for having these discussions about unused embryos. The role of an embryologist, because we are quite often unseen in the fertility pathway. And I also want to talk through some tools for improving conversations around unused embryos and what we could do to improve that. So embryo storage is a routine aspect of IVF treatment. because of advancements that we've had in embryo culture techniques, adoption of single embryo transfer policies, and general improvements in quality of care, a higher number of embryos are being frozen associated with IVF treatment. Embryo storage cycles have increased by greater than 700%, and this is based on HFE data, most recent data. And that just shows that there's an increased access in terms of fertility preservation and increased awareness of the impact of cancer treatments and cancer therapies on fertility and the ability to preserve that. Frozen embryo transfers have doubled in the last 5 years, and over 40% of all IVF cycles are now a frozen embryo transfer. So we are regulated. Storage of embryos in the UK is regulated by the Health and Care Act, and we've almost been, through our own success and improvements in IVF treatment, we are increasing the number of embryos that we have in storage and increasing the number of patients who need to make those sometimes difficult decisions about what to happen and what their wishes are for unused embryos in treatment. As Sarah indicated, these changes in legislations mean that embryos can be stored for up to 10 years, incremental to 55 years. So that consent needs to be updated in 10-year increments, that patients are eligible for up to 55 years total storage. And the HFE Act governs the use of embryos. And again, as Sarah had indicated, those options for unused embryos are dictated by the Act, and it is donated to research, donating embryos to other couples for use in treatment. You can use them, patients can consent for embryos to be used for training purposes, and also that option to allow embryos to perish. So there are a lot of unused embryos, and we need to have discussions with patients on how best to advise and help those patients come to a decision around those unused embryos and what the fate will be. And I think it's really key about who is best placed to have those discussions and support those patients in that decision-making process. So shared decision-making is a concept in healthcare, which is really around a collaborative approach and process between a healthcare professional and a patient, and that's to support decision-making that is in the best interest and for the best outcome of the patient. It requires an evidence-based information about the options available, which is why the person who has that discussion needs to have the level of information and knowledge to be able to have those informed discussions. And it also involves the patient's values and their beliefs and their preferences for their treatment, or in this case, the options of embryos when they are no longer required for their own treatment. Shared decision-making is patient-centred, which is what we're aiming for in a healthcare setting. It's ethical because you are considering the patient and all of these decision-making. It helps promote that informed consent and evidence that informed consent, because patients are being provided with the correct information and the correct tools to support that decision making, and it enables that patients to feel empowered to have that discussion and to have an open discussion with a healthcare professional about those sometimes very difficult decisions. And again, who do we think would be best placed within a service? And from an embryologist perspective, I am going to, lay a foundation and justification that I think embryologists are actually very well placed to have these discussions within a setting. I also want to say that these discussions are not replacing the specialist fertility counselling support. This would happen in combination, so we're not trying to replace this. It's really just about that provision of information and discussing through those options with patients. So embryologists are healthcare scientists. We specialise in handling, culture, storage of egg, sperm and embryos within a centre. And we're trained to make clinical decisions to inform treatment pathways with patients. We provide information to patients, so we need to be able to explain complex information in plain language to patients. We obtain consent from patients, quite often consent to storage and changes to consent to storage, so extensions. We do patient consultations, so we can have discussions with patients about any aspect of their pathway which is related to embryology. And we work with core values, which is a commitment to quality of care, improving lives, compassion, respect, and dignity for patients. That extends to the patient's egg, sperm, and embryos, and the HFE Act defines a special status of the embryo. So embryologists extend that care from patients into the material that they're working with, and making sure that we handle them with respect and dignity. Embryologists are involved in the pathway before, during, and sometimes very often at the end of fertility journeys, but we can quite often be behind the scenes. So I just want to give a little bit of an overview of some of the touch points in treatment where embryologists are involved. And I think this really builds up these kind of key qualities for us to then have discussions at the end with patients to try and come to a decision about the fate of their embryos when they're no longer required for treatment. So treatment processes, we're involved in pre-treatment review. So we're already building up a picture of a patient, even though we may never have met you, about your information about your diagnosis, about how we will best proceed with treatment, and that's to make sure that we're providing the most appropriate clinical care for you. We're involved in the egg collection, so we're, we get that sense of relief when a patient has eggs collected. We're involved in the insemination process and checking to see whether any eggs have fertilized normally. We spend a lot of time looking at embryos and grading patients' embryos so that we can make the correct selection for embryo transfer for treatment. We're also involved in that storage process. And when embryos are then thawed and used in treatment, we're involved in that step as well. So at each step of this process, we sympathise with the patients in terms of their fears and their anxieties, because it's a fear and anxiety that's shared within the laboratory. We worry that a treatment doesn't proceed at any of these stages, that someone doesn't get fertilisation or they don't have embryos suitable for treatment. But we also feel that sense of relief when patient treatment goes well, and that sense of happiness as well when someone has a positive outcome. But we're also involved in the management process of embryos that are stored. We maintain the embryos, so on a weekly basis, we're checking that the storage containers are all fit for purpose, that they're all safe, that we're making sure that the liquid nitrogen that the embryos are stored in is being topped up. And we have external alarms that are on an on-call system that the embryologists will participate in. That means that if there are any problems with the cryo storage out of hours, we will get an alarm call and we attend so that we can resolve those issues. We're involved in the management of storage consents, and we are responsible for contacting patients who have embryos in storage to let them know that they're still there and to initiate these discussions about what the patients want to happen to those embryos in storage. And we're often the first point of contact in that discussion with patients about those choices and what those options are. If a patient chooses to donate embryos, it's the embryologist who is removing the embryos from storage and actively carrying out that donation process. Where embryos have been assigned for training, again, it's an embryologist who is managing that and is removing the embryos from storage for training and assigning them to an appropriate training procedure. And if an embryo has been consented to perish, is to be removed from storage, it's the embryologist who actively removes it from storage and allows that embryo to perish. So we have got a really good picture of the physical and emotional investment that patients have in a treatment pathway to create these embryos. So I think we've got a really good understanding that when we come to the end of that journey, what that can mean to patients. And I think we do have a good skill set in order to have that discussion. So things that we can do to try and improve those conversations when we get to the end of that journey with patients is really about, I think, patient information and patient education is really key. We need to consider appropriate toolkits that can be used, which make sure that all of the options available are discussed and outlined. The information that we're putting together in the toolkits should be evidence-based, it should be accurate, and it must be easy to read. Patients, it shouldn't be overly complicated. Patients should be able to read that information and understand the information that's being provided. It should also encourage patients to think about what the options are, but what their preferred options may be, to try and generate that discussion with a healthcare professional. It should encourage patients to think about questions that they might want to ask as part of that process. And it should also include information about fertility counselling and how to access that. Now, the HFE are quite clear that providing that in writing is not sufficient. So this is supplementary to any discussions that we would have. It needs to be that meaningful offer of counselling. And during the patient discussion, before it takes place, it's important to ensure that the patient has had access to that information and has considered that decision-making tool. And I think it's really important to make sure that you've offered to arrange any additional support that the patient might need or might require. This can be quite an emotional decision for people to make. It can be quite difficult for people to make. So it's just making sure that that additional support has been offered. Now, whether that's a family member, whether it's their partner, if someone does not have a partner and have a connection with perhaps a nurse within the clinic, then these are all appropriate additional support that can be offered. During the discussion, you should think about delivering the information in manageable blocks. That's because this is quite a lot of information. Sometimes it can be quite complicated, the options that are being provided to patients, and there's a lot for them to think about and consider. It's important to check that the information has been understood by the patients and discuss what matters to the patient. Making sure that choice is consistent and their wishes are consistent with the pathway of what they may wish to be consenting to. And it's important to give the patients time to make a decision on this. Again, these can be really complex decisions that they need to make. It's really good opportunity to also take a cue from the patient. Sometimes patients do need additional support. They are really struggling, and again, it's a really good opportunity to direct patients to specialist fertility counsellors to really talk about these decisions before they make that final choice. And after the discussion takes place, it's important to clearly state the decision with the patient to make sure that there is that shared understanding, that the patient's wishes are clearly understood by the clinic, and then agree what the next steps are going to be, and whether that may be counselling, whether it's time to consider and arrange a follow-up consultation, or whether we're talking about changing or amending consent for embryos. I think it would be really good to look at development of decision-making toolkits with the regulator, something that could be led by them, looking at working with professionals, centres, charities and patients to make sure that we get this right. Patient decision toolkits are evidence-based. There's nice guidelines that we can work with, and I think looking at something that could be standardised and used within clinics, I think would be a really useful thing to do, and it would be good support for clinics and really good support for patients. I've said again, patient education, I think it needs to be right at the beginning of the pathway, and just reiterating that these decisions for some patients they may have to make and what they should be considering further down the line. And I think from an HFE perspective, a greater visibility on their website and an ease of navigation. The HFE is a really good tool for patient information, but unfortunately it's not always that easy to find the information that you need. And if I, as a professional, sometimes find it difficult, I think patients will find that difficult as well. So I think finding, having an area within the HFE website, with information specifically on these options, I think would be a really useful thing to have.
Our next speaker this evening is Chien. And Anne is a counsellor at Ninewells Hospital Assisted Conception Unit, and she is former chair of the British Infertility Counselling Association.
Recently, changes to legislation have been introduced, as you all know, to extend storage times. And at this stage, it's bringing quite a bit of uncertainty as to how many patients will uptake extended storage, or how many might decide to let embryos go. It's anticipated there'll be an increased demand on different areas of the services that we provide. For example, storage capacity being increased, there might be financial implications, there may be increased patient contact time, and of course, an increase on the demand of counselling services as well. I think, just picking up on what Joanne said in her talk, I think it's really important for us all to work closely as a team to provide the best care for any of the patients who are having to have discussions about extended storage times and what to do with unused embryos. So just to kind of share with you, many of you may be familiar with the definition of what fertility counselling is. This is the British Infertility Counselling Association's definition. So we offer patients an opportunity to explore their thoughts, feelings and beliefs and their relationships in order to reach a better understanding of the meaning and implications of any choice or action they may take. Counselling may also offer support to them as they undergo treatment and may help them to accommodate feelings about the outcome of any treatment. So this definition is quite fitting when we think about unused embryos and trying to support patients with any difficult decisions that they might want to make. I've been working in fertility counselling for approximately 13 years now. And I can recall one of my very first counselling sessions when I first started in the post. I can recall speaking to a female on the telephone. There were no videos at that point. And I can remember it being an extremely difficult conversation, what to do with unused embryos. It was very emotional. It was impacting on the couple's relationship. They had differences of opinions and they found it really difficult to discuss together. She was really struggling. She was quite isolated. So these are some of the emotions that she was feeling at that stage. Very difficult decisions to make. And it was kind of a decision that she had to make by herself and then go back and speak to her partner. Very, very complicated. It's not for the counsellors to give advice in any way. So very difficult to listen to how difficult this decision was for this individual. At that point, that was a steep learning curve for me, being new in the job. And I realised at that point, there are many aspects to fertility counselling. So since then, I've had the opportunity to provide counselling to a few people who've been considering what to do with unused embryos. And often it may be that they choose to donate those embryos, which would involve implications counselling. But now these counselling sessions may be more frequent and more complicated. There appears to be different options now to consider in relation to extending storage. So following the introduction of the new legislations, as Joanne kind of touched on as well, there's now a legal requirement to offer counselling every time they're approached about giving or renewing consent. So it's important to ensure that the offer of counselling is given when communicating with patients, not just in letters, but also when talking to the patients verbally, if it's appropriate in that conversation that you're having, just reinforcing the message that counselling is available. And if counselling is offered, then this allows the patients to have conversations about their unused embryos. And these, as I say, are quite difficult conversations that can be had. There are different reasons for storing embryos, and recent changes mean that patients need to consider the implications of extending the storage. So it's helpful to explore with them why they might want to consent to extend storage, or why they might decide that they no longer wish to store embryos. So it may be for their own treatment, it may be through donation that the embryos have been created and their implications for extending the storage. They may decide when they have contact with us about what decision they want to make in relation to extending storage. They might decide they want to donate those embryos. It may be for surrogacy arrangements. and it may be fertility preservation that embryos have been stored. Person's age may be significant. It may be somebody who's young, maybe an oncology patient or a patient who's transitioning. So different age groups. They may have stored embryos because it's maybe convenient at that stage in their life. There may be other things to think about. If they've been an oncology patient, what about any kind of health concerns, health risks? And there may be also some financial considerations to make if they're going to extend storage in relation to like finances or whether they're eligible for NHS treatment or not. So prior to consigning consents, it's important to provide the opportunity for counselling and to allow patients to have a fuller discussion about the options which might be available to them. Storage of embryos for their own treatments for a maximum of 55 years now and can be renewed every 10 years. Within the counselling, it may be that we discuss together what might be the pros and the cons of extending storage, or whether they decide to let those embryos go in some kind of ways. There may also be some consideration of what might be financial costs, which might be unexpected costs, hidden costs for individuals when it comes to all this extended storage. For donors, they can store for up to 55 years with the new legislation. And important for implications counselling for us to discuss with the donors and the recipients. If sperm or eggs are donated, what happens if they're donated and then not used for several years? When the embryos are created and the children hopefully are born, the child may, when they're 18 or over at the moment, wish to contact the donor, but how old might the donor be by that stage? So it's extending all of that. And it may be important for implications counselling for the counsellors to discuss with the donors, for example, how long might they want their sperm or eggs to be stored for. So some quite significant changes to the implications counselling aspect of it. More recent kind of conversations that I've certainly had with patients has been in relation to this kind of transitional period that we're going through at the moment for the patients with embryos in storage who can benefit from extended storage period. Counselling allows more time for individuals in a confidential and safe setting for them to fully explore and consider the options, to take their time to do this, because as Joanne said, it's a really difficult, important decision for them to make, and it's important that there's consistency in the decision or the choice that they make. So really important to ensure that they're fully informed and that they understand all the options available. The counselling sessions provide them with an opportunity to consider and reflect upon their thoughts and feelings in relation to any of the options and any of the implications. It also allows them time to grieve. Receiving from clinic letters, may bring back memories. Suddenly these letters are arriving unexpectedly. They've perhaps anticipated that at some point they'll have to make a decision, but they're maybe not expecting to receive these letters that we're now sending out, or the contact that we're having with the patients. So really important to allow them to have an opportunity to kind of think about things, to allow them to grieve. It will open up some of their wounds, if you like. Memories might come back, emotions might come back, which can be quite difficult. And no matter which option they decide, what choice they make in relation to their embryos that may be stored, I think it's important to allow them to go through grieving process if that's significant for them. So it's important also to think about the differences between individuals. We have different meanings and beliefs, and to be kind of sensitive to those and respectful of them. Sometimes there's differences between males and females, as we all know. Sometimes there may be differences in what the meaning of the embryos are to individuals. For many, it may have a very personal meaning and attachment to those embryos is quite an emotional thing. And for others, they may see it as cells and something a little bit more clinical. So how they kind of see those embryos are really important. It's important to provide emotional support to the patients coming through. And as I said earlier, really important to be able to allow them an opportunity to discuss what their thoughts and feelings are in relation to all of this in a safe space, which is also very confidential. There are different options, I guess, as Joanne has already mentioned, to let the embryos go, to donate to research or to others, and for training purposes. When thinking about options for unused embryos, through talking to some of the patients more recently, they also feel that this is opening up something for them in relation to when do they tell their children if they've had fertility treatment. They may not be at an age where they can start to talk to them about this, but because we're working from those who've been stored longest, some of the children are of an age, and it's opening up whether we start to talk, whether the patients start to talk to their children and tell them how they've been conceived and a little bit more about what they've been through and their kind of personal journeys. There's something about reaching a sense of closure, so helping them to make a decision, allowing them an opportunity to discuss things, help them to perhaps make a decision and bring this sense of closure, which might be quite beneficial. Some of our patients may want to consider some kind of a ceremony. They may want to allow the embryos to perish, and then they may want to do something quite personal. They may have an opportunity to take those embryos home afterwards, and they may do something very, very personal with them. I just want to kind of make you think of some of the cases that we're actually considering and trying to support. The first is a heterosexual couple who, it was a 19-year-old female, was diagnosed with lymphoma, came to us for fertility preservation and was in a relationship, so we created embryos. After treatment and after their treatment for their lymphoma, the individual unexpectedly conceived naturally. They've recently received a letter from a clinic and saying that they've got their embryos stored and what do they want to do in relation to extended storage. This individual is really confused. She does want to have family in the future, more family. She's wondering whether she's fertile or not. Does she need to use those embryos? And now, because they've got a child in the household, they may not be, well, they won't be entitled to NHS funding. So what about the financial costs? So quite complicated, a lot of uncertainty, and really difficult for them to decide what might be the best option here. The second case I wanted to just mention, I'm going to change it to another heterosexual couple. I've been given consent today just to share a little bit about somebody that I've spoken to very recently. So it's a couple who've had treatment about 9 years ago. They've got 2 children and are very happy with their family. They had IVF. They've got about 3 embryos in storage. They received a letter from the clinic recently and were unsure what to do, so they asked for a counselling appointment. So we explored together the thoughts and feelings in relation to the embryos. It was the woman who attended, her husband was unable to attend. She said that she knew that this decision would come at some point, but she kind of parked it and didn't want to think about it over the years. But now she's faced with, we need to make a decision. The couple are very religious. It's a really difficult decision for them. She's got a lot of personal attachment to those embryos, and she's finding it really difficult. She praised up the staff when we were talking about her experiences. She recalled exact words which were shared when she was coming through for treatment. And in particular, it was the words of one of the embryologists who said, "You've got 3 good embryos stored." So she's held on to that. And what has kind of the decision that's been made through the counselling and through her kind of discussions with the embryologists and with her husband are that they've decided to let those embryos go. They want to come into our unit and then collect the embryos and take them home. And what would be very personal to the couple is for that same embryologist to hand the embryos that have perished over to them. And to them, that feels like that's come full circle and feels very, very personal and comforting to them. So it's brought them a sense of comfort. So very complicated, very difficult decision. But if we can find a way to support those individuals, to find a way for them to make those choices, to help them to make those choices, then it can be a more positive experience. And just the complexity of the kind of extending the storage times, it's thrown up things that we hadn't considered. Another letter has been sent out to another couple, and they have their children. It seemed that they were, their family's complete, and sadly circumstances can change. And sadly, one of the individuals has recently passed away, and now to receive this letter at this time has been extremely upsetting for them. And it's too soon to let a part of the partner go, thinking about the embryos. So these are really tough conversations which several of the team are having, especially the embryologists who have that kind of first point of contact, and then of course the counsellors as well, and any other members of the team who are involved in this. So some aspects to consider. The end starts at the beginning. Think about the language that's been used all the time when we're talking to our patients. Think about those words, these are good embryos, which the embryologists use, and individuals have held on to those words. Think about communication skills that we're using. We need to be sensitive, non-judgmental, be genuine, accept what the individuals are saying, listen very carefully to them, consider and reflect on what they're saying to us, and consider any projection of emotions. So using basic counselling skills when we're communicating with them. Individuals can be quite passive. Perhaps they've avoided dealing with the decision what to do with unused embryos, but now they might need to face this and talk about it, and they can be very, very difficult decisions for them to make. Embryos are full of hope when they're created and expectation, and to make decisions about what to do with them are very, very difficult, as I say. I've already touched on they may have different meanings. Embryos may have different meanings to individuals. It may be more clinical or personal, and I think it's important to respect and be accepting of different religious beliefs. So these conversations can be complex and emotional. It's important for us to support the patients with these difficult decisions as best we can. The offer of counselling should be given before, during and after any treatment to ensure that the patients feel supported throughout their journey. It's also difficult for some members of our teams, depending on what these conversations are like. They can be upsetting sometimes, and I think it's extremely important also to remember to support each other when we're working in a team as best we can. I just want to share with you what the patient said to me this morning. So although it's been very good and everybody's been very caring towards us, we don't see much of the doctors and the embryologists. The link with the counsellor was more personal. The conversations stick even 10 years later. It makes it more bearable to have support. It's unique and it's a daunting experience to have treatment, which stays forever. It's not just about the service, it's about the people you connect with. So that's the staff in the service. To have someone saying it's okay, it's unique, you'll get through this is supportive. And the coping strategies we've learned through the counselling have helped, and we've continued to use these. In relation to the unused embryos, we've put this off for years, but feel a relief, closure in such a nice way for us and our daughter. So it's comforting that the embryologist and the counsellor who were there at the beginning are also there at the end, and it's gone full circle.
What evidence do healthcare professionals use to discuss and help patients decide about embryo storage? And are they qualified to help patients make clinical decisions?
Embryologists undergo a 3-year training programme which gives them the skills to make clinical decisions. So it's building in qualifications, experience and knowledge. And are registered within the UK to perform that role. We also make sure that we keep up to date with any continuing professional development, and there are additional courses that we would do to upskill and increase the tools that we have and that we apply. We have a lot of information that's available within the clinic. So we do have a lot of patient information that has been put together using evidence-based literature reviews. So we always make sure that the information that we're providing is scientifically sound. We also take into consideration the legal framework that we work in, and people who work within an HFA licensed centre have a deep understanding of the regulation and the framework that they work within. So, what I would say is that the healthcare professionals who work within centres, do have, the skill, the knowledge and the experience to undertake these discussions with patients. We also understand our own scope of practice. So if there is something that a patient is wanting to discuss or requires to discuss that needs further follow-up or referral to a more appropriate professional to have that discussion, then that's certainly what we do. From an embryology perspective, we're a kind of first line of discussion with the patients, and we will signpost and refer to other professionals where needed.
How does this perishing happen? How does someone take them home afterwards? How big are they? What kind of container are they in? Are they visible to the naked eye?
Embryos are not visible to the naked eye. In order to observe them, you need to look at them underneath a microscope. So they are not visible to the naked eye. In terms of taking embryos away from the centre, we don't allow that within our centre. The guidance that we had been given is that we couldn't release embryos that had been stored for patients to take home with them. So certainly from our centre, that's not something that we're able to permit. So the HFA provide a guidance document. It's a code of practice. It helps clinics make sure that they're compliant with the law. There isn't much detail in there around how to perish an embryo or allow an embryo to perish, but it does state that there need to be protocols in place within the clinic to make sure that that's done, and making sure that there's the respect of handling embryos. So within my clinic and within a lot of clinics, it's a passive process rather than an active process. The embryos are stored within liquid nitrogen, and as long as they're stored within that environment, then they will remain biologically static and can be used in treatment. If we remove them from those conditions and then don't place them into culture, then the cells will undergo a natural cell death. They are removed from storage and those conditions that would support continued growth.
We have embryos in storage that we'd like to donate to other families, but are unable to do this as we use donor sperm, which has 10 families already, including our own children. Do you know if there's any way around this?
Unfortunately, I don't think there is a way around this. There is a 10 family limit within the UK. What I would suggest is get in contact with your clinic and perhaps ask them to reach out to the regulator. There is, embryos are a really precious resource, and I'm not saying this to get anyone's hopes up that they may be able to be used, but I think go back to your clinic and ask if the clinic has had any direct discussions with the regulator. They may have done that, and if the regulator has said that they cannot unfortunately be used in treatment because it is a breach of the 10 family limit, then unfortunately that is the answer. But certainly if it happened within my clinic, I would explore that further with my inspector so that we had a confirmed answer for the patients.
It would also be worth double checking really that 10 families had actually been created and that they'd been used in 10 lots of people because they may not have had successful treatment and may have used all the embryos that they created, which would be very sad for them. But that's also worth looking into because that may help. The next question is also from an anonymous attendee. Are clinics, especially private clinics, allowed to discard embryos where a patient is no longer paying for storage, but the embryos are still within their consent period?
The HFEA are quite clear that your storage consent is separate from any contract that you sign with a centre around the storage of your samples, so egg, sperm, or embryos. So they are two separate, and it's quite clear in the code of practice. I do know that there are practices where centres will remove samples from storage on non-payment if that is part of the contract. Whether they're legally permitted to do it would depend on the content of the contract and the legal advice that the centre has been given around the use of a contract and the separate storage consent. So my understanding is that until it's challenged, then if there is a contract in place and patients have entered into that contract and that arrangement, and that they are aware that on non-payment that embryos would be removed from storage, then I think centres are certainly acting within the legal advice that they've been given.
The HFEA Chair Julia Chien has said that the regulator is interested in allowing broader consents for patients donating embryos for research as part of the reform of the Human Fertilisation and Embryology Act. Do the panel think that the option to donate to an embryo bank, which is what is in the HFEA's consultation, would make it easier for patients who wish to donate for research and more straightforward for clinics to facilitate this? So I think we'll perhaps go to Anne first and then Sharon.
I know from my experience of individuals who want to donate embryos, which is quite limited in our unit, is that they have donated embryos to people that they know, and there's something about they want to feel reassured that they will be good parents, the recipients will be good parents.
This is a question about an embryo bank for research purposes only.
So, yeah, I would think that might be beneficial to have a bank for research. Sorry, I misinterpreted that.
Not all clinics have a link to research, and so for some patients it means that donating to research simply isn't an option. Without a lot of extra burden.
You're absolutely right, and we have had the patients on the phone. Wasn't that long ago when I spoke to a patient who had decided that they did want to donate theirs to research, and it wasn't viable with the clinic that they were at. It was a small clinic, South England. So for the clinics that are not attached to research, definitely.
Where we're sitting in terms of research at the moment is a centre has to be licensed for research. It's a specific project. If you want to attach yourself to that centre to send your embryos there for research purposes, there's a lot of administration that then has to go on with the centre where the research is taking place. It becomes very arduous. I think anything that's improving options for patients, and it comes down to that provision of information, making sure that the patient knows what they are consenting to.
Have you received any feedback about the language of perish or destroy? In the US, the language is of abandonment. For patients struggling with these decisions, these words can inadvertently be amplifying the difficulty.
This is something that we discussed recently at a BICA workshop, how important the language is that we use when it comes to this. And we did share some different ways of like letting the embryos go. I think I used that term tonight rather than perish.
I think destroy, discard, and perish are really negative words. And they're really, we need to try and look for another way to, actually explain this to patients that take away, those negative tones that all those words carry, and look for some other way that we can actually, explain it to patients and take out some of the emotion.
It's a really emotive and sensitive area, and as Anne and Sharon have both given examples, from patients and the impact on patients this language can have. So key is getting that patient engagement and involving the patients in how to frame that language and that discussion around the fate of embryos.
From some work that PET did, it's incredibly difficult to come up with some words that are clear in their meaning of what's happened as well, because you don't want people ultimately to be confused that the embryos have, are no longer there. There's that need for clarity but sensitivity. A note about the point on language. It's important to remember that many patients do not speak English as a first language, and phrases such as letting go may not translate too well and lead to confusion. And so it's vital to be specific and unambiguous whilst being as sensitive as possible.
Most of this contact initiates through a letter or communication that will be sent to a patient. Is it appropriate to have an option of how we would refer to this on a form, and the patients could indicate their preference, their specific preference on how we would like to use, what language we would like to use to talk about, letting go or perishing, and making sure that there was a clear communication of what that actually meant.
But then I'm thinking, if I was a patient and I still received that letter and those words were there, I might still get upset. That's my only. But I think it's good to think about choice. I think that's interesting to consider, Joanne.
I'm going to go now to a question from Kay Elder, who says, in our clinic, patients must pay an annual fee for continued storage. And this is administered via our patient services finance department. It's hard to imagine that any couple would consider continuing to pay for this for up to 55 years. Are there IVF clinics where embryos can continue to be stored for very long periods of time without any charge?
Certainly at our clinic, there are no charges at the moment for storage. There's no storage fees for anyone who's eligible for NHS funded treatment. Any patient who self-funds, then annual storage fees would be applicable, but certainly for patients who enter our service as an NHS patient and have embryos created, there are no storage fees applied to patients within that first 10 years of consented storage period. So we do have a very different situation in Scotland, where some of the clinics are not applying and have not applied storage fees to patients who are storing for NHS purposes. But it does mean that patients are delaying that decision-making process because there is no financial incentive or detriment to those embryos remaining in storage. So we do find that more patients delay that decision to the end of the 10-year storage period.
What's your opinion on increasing the overall possible storage period of frozen gametes and embryos to 55 years? Does it make the decision making for patients even more difficult?
The decision making perhaps is more complicated. There are more options, as I said in my talk, to consider. They may hold on to the embryos a bit longer, just delaying that decision making. I think it does make it more complicated, and it makes them think about, I think perhaps it'll make them wonder what to do, what the choice they want to make, just consider it a little bit more, because there are different choices now to extend that storage period. Hopefully it'll open up discussions. I think it's early days to really know what it's going to be like.
For some patients, it's made it really easy to kick the can down the line and not even look at what decision they need to make. And that's probably more so for patients that are within the NHS who have got free storage, so it's doesn't even have a financial implication to them. But I think it has allowed some patients to, just push that decision to the back of their mind again for as long as 55 years. For other patients, actually getting these letters out, they've maybe been thinking about it, and it might be actually helpful. But as I say, because there are options, I think it's swings and roundabouts. Some will just. I'll be really interested to see the statistics in a few years from now. How many patients are actually responding to the clinics when they get those letters? and what has been the patient's feedback?
Giving patients more options, I think, is a positive thing. I think it's key about the provision of information to make sure that patients are making the right decision for them. I think there may be situations where they can just kick it down the line, but again, that comes back to making sure that those patients are properly informed at the time of that decision making.
Some clinics only allow one counselling session. How can you make an important decision in one session? Maybe these clinics need to be more compassionate when patients are faced with these dilemmas.
That's really sad to hear, and I know that that is what happens in other clinics. We're very fortunate. I work in NHS and the number of counselling sessions are open-ended before, during and after any treatment, as I said earlier in my talk. I think these are very complicated decisions. I think it must be extremely difficult for some people to be able to talk about their kind of thoughts and feelings in relation to this in one session. I think it's very, very difficult. And they may need time, they may need to, perhaps have a counselling session, go away and think about it, or have some contact with the embryologist, for example. It takes time to make the decision. It's not something that you want to rush. And it's something that, you would hopefully, they would have an opportunity to come back and talk about again if there are things that, they need to discuss a bit more fully with the relevant members of the team. But certainly for the counselling, I think there should be more than one session. I think that's really important. And hopefully that's something that some of the clinics might consider and increase the counselling sessions being offered.
There's a couple of questions about that seem to have an agenda about whether embryologists are qualified to have these conversations with patients. I sort of feel that you've sort of slightly answered that already, Joanne, but I just wondered if there's anything you wanted to add.
I'm not suggesting that the embryologist knows the answer to everything or has the knowledge to answer every question, but I think they're a very good first line discussion with patients, and we tend to be the member of staff who's writing out to them. So we are managing the storage of embryos and we're contacting the patients. We do have a long training program that gives us the skills to be able to have discussions with patients, to provide information. So yeah, I'm not sure why anyone would think an embryologist is not well placed within a fertility service to have these discussions, because it is just part of our training, and part of the service that we provide is taking very complex information and discussing that with a patient and helping the patient make a decision about their treatment and help to inform treatment pathways. We're just as qualified as a doctor to have some of these discussions, and we always refer and make sure that people are provided with the additional support from the correct professional, including the specialist fertility counsellors, for that type of therapeutic support in this situation. We do work in a multidisciplinary team, and we get a huge amount of support from our counsellors, so they frequently run in-house training workshops on delivering bad news with case-based scenarios that we work through. So yeah, we're really well supported by our counsellors, and I know that the other clinics in Scotland are equally well supported by their counselling team.